Good afternoon, everyone. I am Courtney Flukes, the Executive Director of Association Northern California Oncologists. Today, we are having our webinar on a breakdown of H.R.1, the big, beautiful bill, and its impact on the future of healthcare. Together with our ANCO and MOASC lobbyist, Cher Gonzalez, she will be providing an update. Cher.
Hello, everyone. Good to see all of you. Thank you so much for joining us. I know you've probably seen a million presentations on HR1 by now. I'm just going to put it into the context of where we're already at in California in regards to our budget situation, because it's one thing to hear, for example, if you had to buy a new air conditioning system for your home and you found out it was going to be $50,000. $50,000 is arguably a lot of money to anyone objectively, but that $50,000 means a great deal of difference to the family that has $500 in the bank account and the family that has $500,000 in the bank account. And right now, because the state of California is being it has been experiencing fiscal deficits, fiscal shortfalls. We are the family that only has $500 in the bank account. We don't have enough money in our accounts right now at the state of California to take on additional shortfalls. So that's what I'm going to be sharing with you, is just how is it going to impact California? And what are some of the things that California might do in response? So let's jump on in. Okay, so let's just give the bottom line before I even, go through the steps. What are the top lines that you need to remember you need to take away from this conversation? The bottom line impact of HR1 to California, according to the California Health and Human Services Agency, up to 3.4 million Medi-Cal members may lose coverage, and California will lose annually $30 billion from federal funds annually. Now, I want to put that into context. We spent about $45 billion on the Medi-Cal program from the general fund. So if we're going to lose $30 billion in federal funds annually, that almost doubles what we would have to make up for in the general fund. So that's a huge, huge hit. And I don't know how you get to that point of making up 30 billion without making very significant reductions in spending and possibly raising revenue. According to the California Hospital Association, Medicaid and Medicare revenue losses to California hospitals will be between 66 billion and 128 billion over the next decade. And according to the California Medical Association, health system contractions are projected to eliminate 217,000 California healthcare jobs and reduce economic output by 37 billion and cut 1.7 billion from state and local tax revenues. So those are sort of the top lines to walk away from this presentation. But let's get into setting the stage. Where were we at with our own fiscal situation, our own budget in the state of California for 2025? The 2025 Budget Act put together a spending plan that addressed a $12 billion shortfall, meaning there were $12 billion in expenses that we did not have based on our revenues. Total spending of the Budget Act for 2025 was $321 billion in total spending. 228.4 of that was from the general fund. We still have reserves left, which is the good news, of $15.7 billion. So they were able to address the budget shortfall and create a balanced budget. And we still had $15.7 billion left over in our rainy day fund or savings account for the state for future shortfalls. The 2025 Budget Act, let's just go over it real quickly. How did we address this $12 billion shortfall? We did it in a number of ways. It was reductions in spending, i.e., cuts to spending, revenue borrowing, shifting funds from this account to this account. We have a lot of special funds in this state, so you can borrow from those special funds and move them over to the general fund. You can delay spending. So it was a lot of accounting tricks. The California Senate Republican Fiscal Office put together a handy little pie chart so you could see the reductions were only about 23% of the solutions to address that $12 billion shortfall. A lot of the other stuff was a lot of accounting tricks. Medi-Cal spending, a huge portion of the $12 billion in our shortfall came directly from the Medi-Cal program, and that's not good news for any of us who work in healthcare. $6 billion of the $12 billion shortfall was because of the Medi-Cal program. $1 billion of that was related directly to pharmacy spending more than we had projected, spending more than the state has. $1 billion of the shortfall was just related to Medi-Cal pharmacy. The other $5 billion was related to Medi-Cal caseload, and that primarily came from the undocumented expansion, but it also came from an elderly population that it was able to get onto Medi-Cal because of some changes in rules regarding the asset limit test. And as a result, we had higher than projected caseloads this year. So $6 billion of the $12 billion directly because of Medi-Cal, $5 billion of that mainly from the undocumented, some from the elderly, and $1 billion of that from pharmacy. So they did a variety of things this year to try and address the Medi-Cal spending, which resulted in half of the budget shortfall. You can see that they, from the 2025 Budget Act solutions that I have here, they did a variety of things. They upped the minimum rebate for cancer and HIV drugs that manufacturers are required to pay to the state. They upped that from 10% to 20%. It equaled $75 million in savings. They eliminated pharmacy coverage of OTC drugs. They started utilization management and prior authorization and step therapy protocols. So those all added up to some savings. And they also created a prior authorization protocol for even continued therapies. And they eliminated coverage for medications for weight loss. So those are a number of the strategies they utilized on the pharmacy side. Setting this up for HR1. So what did that mean? What does the 2025 $12 billion shortfall mean for the future of California, especially when HR1 is also going to result in what we saw was $30 billion estimated annually of a loss to California in federal funds. The future projections for the state's budget are not good, and it really depends on who you ask. The Department of Finance, which works for the governor, the Department of Finance projects that operating deficits are going to range from $10 billion to $20 billion over the multi-year period. The California Senate Republican Fiscal Office does not have as rosy of a project, and they're projecting that California will see shortfalls from $17 billion to $24 billion. Now, what is the truth? The governor's office, the Department of Finance is saying 10 to 20 billion. The Republicans are saying 17 to 24 billion. It's probably somewhere in the middle, right? Republicans would probably like to make the fiscal situation not look quite as rosy as the governor would like to, right? So it's probably somewhere in the middle. What we know is that it's going to be budget shortfalls over the next few years, and they're going to be very significant shortfalls. And then we have the managed care organization tax. I'm just going to go over this really quickly because you'll see in the presentation on HR1 why the managed care organization tax is important. In the 2025 May revision, the projected managed care organization tax revenue, which upholds the Medi-Cal program, that money goes to support the Medi-Cal program, $9 billion was from the managed care organization tax in 24-25, $4.2 billion from the MCO tax in 25-26, and a projected 2.8 billion in 26-27. That's incredibly significant, especially when you look at that 9 billion number when I said that 45 billion of is what we spent on the general fund, right? So that's at 9 billion as a significant percentage of 45 billion. The managed care organization tax has always been an incredibly important part of keeping our Medi-Cal program up and afloat. And we're going to see as a result of HR1, that's now going to be in jeopardy. All right, so what are the HR1 Medicaid provisions? Now I've
Cher?
told you like where we are at in California. I'm sorry, did I have a hair
Yes,
question?
we do have one question for
Yes.
you. What caused this disaster of shortfalls?
That's a very good question. So the $12 billion shortfall that we had this year, 6 billion of that came from the Medi-Cal program. So half of that was from the Medi-Cal program. And that's because of the increased pharmacy spending that they did not predict, $1 billion in increased pharmacy spending and 5 billion in the increased caseload costs. And that mainly came from the undocumented. The other 6 billion came from lower than projected revenues and a variety of other mechanisms. But that's sort of how we got to this 12 billion sort of disaster that we had to deal with this year. And then in the future years, those projections of 10 to 24 billion is all because our current spending is not matching the revenue coming in. We're outspending our revenue, and that has a variety, the revenue is a variety of reasons. The economy is not doing too well. And as a result, because of the way California makes its money off of tax revenues, when the economy takes a hit, the California budget takes a serious hit. Now, HR1, the Medicaid provisions in HR1 are sort of broken down into 3 buckets just to make it digestible for you because there's so much about HR1 to understand. But let's break it down into 3 buckets for Medicaid. One is eligibility and access requirements. One is the state financing restrictions. And then the third is the immigrant coverage limitations. We're going to go through each of these and show you how it's going to impact California specifically. So the access requirements, and we're talking about the work requirements. I'm sure many of you have heard that there's a term being bandied about able-bodied adults and their requirement to work. Now, there are exemptions from the able-bodied requirement to work, and those exemptions could be you are medically frail, you are intellectually disabled, things of that nature. However, unfortunately, even if you qualify for those exemptions, say you are a child who is now an adult who was born with severe autism, you have always been disabled, you will always be disabled. You are still going to have to, or your family and caregiver are still going to have to redetermine your eligibility every 6 months, even though it's agreed that you're never not going to be severely disabled. You're still going to have to do that every 6 months to say, yes, I am qualified for that exemption. That in of itself is a concern for many people because this is a concern that the 6-month eligibility will result in people simply losing coverage. Not everyone has great caregivers to help them keep up with the 6-month eligibility. Some people move, some people are homeless. There are a variety of reasons why someone would not be able to keep up with a 6-month eligibility. And as a result, that's something that people are greatly concerned about. The state this will go into effect on January 1, 2027. States can have an option to request delay of implementation until December 31, 2028. But that's with the HHS Secretary's approval. And last time I checked, the Trump administration and the Newsom administration are not getting along too well. So it's anyone's guess as to whether that delay in implementation would be granted. Also, there are going to be cost sharing requirements that go into effect as a result of HR1. those individuals with incomes above 100% of the federal poverty level. What does that really mean? Well, in California, 100% of the federal poverty level is an income of $15,000 for one person or $31,000 for a family of four. States will decide the amount, but it shall not exceed $35 for services, and it would be subject to an aggregate limit of 5% of family income. There will be a copay for drugs as well. Cost sharing would be $4 for preferred drugs and $8 for non-preferred drugs. Bottom line impact, this and other things that we'll talk about. California is estimating that they will lose 3 million Medi-Cal members, increasing costs for hospitals and clinics for now uncompensated care for the uninsured, because they will lose their Medi-Cal coverage as a result of these work requirements and the eligibility determination of every 6 months, as well as the cost sharing. All right, state financing provisions, the managed care organization tax that I was talking about. There's a reason why I went over why it was so important to the Medi-Cal program to keep it going. That's because as of July 4th of this year, our managed care organization tax in California is not compliant with H.R.1. It will need to be redone. In addition to that, in October 1 of 2027, there's going to need to be a tax amount ramp down. So currently in California, we are at 5.99%, which is the limit. 6% is the limit right now under HR1, and it will have to be reduced by 0.5 percentage point per year until it's 3.5%. So you can see now that this is of great concern, because California is now going to have to figure out how they redo their managed care organization tax. And then even when they redo it and get federal approval for how they've redone it to get be compliant with HR1, the problem will be, even once that happens, we're going to need to take considerably less over the years than we currently take in right now, which means the state will need to backfill that loss eventually. All right, immigration Medicaid coverage limitations. I know you've probably heard a lot about this. This is of great concern, particularly for hospitals and therefore patients in rural communities who may not have great hospital access as of the current situation, right? So emergency services as of October 1, 2026, the feds will not be providing that 90% matching rate for emergency services that are provided to the undocumented. We now call them unsatisfactory immigration status, UIS, but just for clarity, I'll just refer to the population as the undocumented. So there will no longer be a 90% match for ER services to the undocumented, which means that hospitals will now be picking up that cost of care. That cost of care will now be uncompensated. And what does that mean for ER access in rural areas? Will it mean that some hospitals will simply close their ERs? I don't know. Those are some of the things that the hospitals are talking about right now. It also means that there won't be a 90% matching rate for emergency services for refugees and asylees and other individuals who are legally in the country. All right. Another issue on the immigration on Medicaid coverage limitations is the federal funding, the federal match for full scope Medi-Cal for people who are legally within the country. So now we're no longer talking about the undocumented. We're talking about people like Ukrainian refugees, human trafficking victims who have a T visa, a trafficking visa. These are people who are legally in this country, but effective October 1, 2026, there will no longer be a federal match for those individuals to receive full scope Medicaid. Now, what does that mean? That means that hospitals again and clinics will not be getting reimbursement, and that ups the amount of uncompensated care these organizations are looking at. And now you can see why the hospital systems are so nervous in California right now. Mitigation for rural health, the feds did sort of anticipate that all of these cuts would hit rural hospitals the most. So they did come up with a $50 billion program. That funding will be distributed 10 billion a year from 2026 to 2030. 50% will be distributed to the states equally who submit approved applications, and 50% will be distributed per the CMS's discretion. I don't think that that 50 billion is going to make up for all the losses we're going to see here in California. So I don't think it's better than nothing, but I don't think the hospitals are thinking that this is the end all be all in all of the problems that we're going to see as a result of H.R.1. Next steps is California does need to submit one of those applications to get the funding for the mitigated rural health to mitigate the harms coming to rural health providers. And that application will be due December 31st of this year. Looming ahead is Covered California. The enhanced premium tax credits are set to expire at the end of 2025. And if our Congress does not act, there's going to be a major problem here in California because Covered California projects that people's premiums will go up an average of 66% if these enhanced premium tax credits are not extended. And they estimate as a result, 400,000 people that currently have healthcare coverage will lose that healthcare coverage. Again, adding to the amount of uninsured that will still show up to hospitals and ERs and clinics for care. 66%, I don't know how many people in this state could afford a major bill like healthcare premiums going up 66% all of it at the same time, but 66% every single month as an increase in cost. Many households will simply just not be able to afford to hold their coverage any longer. And that's why Covered California is projecting a 400,000 drop in insurance coverage in the state of California.
Cher, we do have a question.
Yes.
Are all states facing similar?
All states are facing very big problems, and that's why you see even Republicans like Marjorie Taylor Greene begging Republicans to please pass those ACA tax credit subsidies before they expire this year. However, I will say California seems to be getting the worst of it all because, for example, our MCO tax, we take in a lot of money through the MCO tax, probably much more than most states. So it does in particular harm California, as well as we have not just a large undocumented population, we just have a large immigrant community in general. And so as you recall from the previous slides, even if you are here in the country legally, the state is going to lose that federal match for those Ukrainian refugees or human trafficking victims and those types of asylees. They're still going to lose that federal match. And we just have a larger immigrant population than, for example, Iowa or Nebraska. So it does particularly harm California, I think, the most. And then this is Covered California's chart, as you can see just how much they anticipate the healthcare premiums will go up if we do not receive those enhanced tax credits this year if they're not extended. Other provisions of H.R.1 that aren't in the healthcare bucket, but they're severely going to impact our budget, is the changes in the Supplemental Nutrition Assistance Program. In California, that's known as CalFresh. As a result of those changes, California is projecting that they will see a drop in federal revenue from 1.7 billion to 3.7 billion annually. Now, put that onto the 30 billion annually we're going to lose in Medicaid funding. And now you can really see that this is a very serious problem when we're looking at a budget that was already projected to have deficits in the future anywhere from 10 billion to 24 billion. So we go back to the first slide. In law school, they always told us, tell them where you're going when you're doing a presentation or you're making an argument, tell them where you're going, go there, and then tell them where you went. So we come back to the first slide, the bottom line impact to California. $30 billion in federal funding is at risk annually because of the changes in Medicaid. The changes to SNAP will be another 1.7 billion to 3.7 billion. 3.4 million Medi-Cal members are anticipated to lose their coverage. The California Hospital Association anticipates that the revenue losses to California hospitals will be between 66 billion and 128 billion over the next decade. And the California Medical Association anticipates that the health system contractions are going to eliminate 217,000 California healthcare jobs. It's going to reduce our economic output by 37 billion, cut 1.7 billion from state and local revenues, and uncompensated care is anticipated to surge to 9.5 billion over the next decade. What will the California legislature do? They are on recess right now. They're on interim break. They gavelled down in the middle of September. The governor has also ended his veto session. And so now the legislature will not be coming back into town most likely until January, although the governor could always call them back into town for a special session to deal with the budget. We do know that the California Senate is already floating a plan to increase revenues, and that is through what's often called the Walmart tax. The Walmart tax is a tax proposal that would tax very large employers with very large percentages of employees that receive Medi-Cal because they don't receive health care through their employer. Now, this almost always only fits Walmart. Walmart is rather famous of hiring a workforce of all part-time employees. And so those employees are part of the working poor, and those employees are on Medi-Cal. The taxpayers essentially subsidize Walmart's employees to have health care. So the California Senate Democrats are going to put together a plan and propose it as a way to increase revenues to take care of the Medi-Cal program since we are going to lose so much in federal funding, and I just don't even know how we cut that much to make up for those losses. Seems we may need to raise revenue. This is one of the proposals being put forward, is the quote unquote Walmart tax. Other organizations have talked about, such as the California Assembly, we just talked about the California Senate, talked about a Walmart tax. The California Assembly has just said there needs to be probably a special session of the legislature in the fall to deal with the budget situation, or we may need to just deal with the budget situation in January. Now, the California legislature, the way it works is that the budget is proposed by the governor in January, and then the legislature has essentially until June 15th, which is the constitutional deadline, to pass a budget. The California Assembly is floating the idea that we may need to pass a budget actually in January to deal with all of these budget shortfalls, and then progressively keep on passing various budget solutions throughout the year. And then the Legislative Analyst's Office, which is the nonpartisan fiscal analyst to the legislature, has said you probably need to look at increasing your ongoing revenues and reducing ongoing spending. That's their way of saying you need to make a lot of cuts, and you're still, even with those cuts, going to need to raise revenue somehow. I'm going to end our discussion with that and see if there are any questions. I will put this up here just so you could see there are a variety of things that the executive branch and California legislature could do over the years to come, and see if there are any questions.
Cher, we do have one question, but it's not regarding HR1. They are wondering if you could speak to California's Governor Gavin Newsom signed into law multiple healthcare related bills passed by the state's legislature, including Senate Bill 41, which is intended to curb certain pharmacy benefit manager practices, SB 306, which will phase out prior authorization requirements for commonly approved services and prescriptions, and Assembly Bill 1415, which will require private equity firms to notify the Office of Healthcare Affordability before completing major transaction in the healthcare sector.
Sure. Well, I love policy-minded people asking policy questions. That's always exciting. Yes, very exciting that SB 41 was signed by the governor. That is the PBM reform bill. It does prohibit certain activities by PBMs, such as steering patients away from their current pharmacy to the pharmacy owned by the PBM. Most notably, that bill only applies to the pharmacy benefit, right? So we do know, for example, that PBMs are doing this on the medical benefit as well for physician administered drugs, such as infusions, steering patients away from their own oncologist to receive chemotherapy, instead steering them to an infusion pharmacy that they just happen to be vertically integrated with. The bill does not include, so the bill does not address those practices. It's clearly only applies to the pharmacy benefit and steering patients away from one pharmacy to another. But another thing it does, which is wonderful, and along with the governor's trailer bill language, is it finally regulates PBMs. We have been the wild, wild west out here, where every single entity in the healthcare space is regulated by the state of California, but not PBMs. They're not regulated by the feds. They're not regulated by us. And now finally that's going to change. So very exciting on SB 41. On the prior authorization bill, that was the California Medical Association bill. What that bill does is to say, hey, health plans, you're going to need to submit your data on all the services that currently require prior authorizations. And you're going to need to submit that data to the Department of Managed Healthcare. The Department of Managed Healthcare is going to comb through that data, and you're also going to need to submit the data, how many times those were approved, right? So how many services what kind of services require prior authorization, and how often were those approved. The DMHC will comb through that data, and then it will come up with a list of services that always receive 90% or more prior authorization approval. And the DMHC will then come out with a list to say, okay, health plans, you will pretty much always approve these prior authorizations for these types of services. So now in the state of California, you can no longer seek prior authorization for those services. That will be a multi-year effort. Don't quote me, I don't have the language on when exactly the milestones for the reporting and when the DMHC's report comes out, but it will be a couple of years of a multi-year effort to do that. And then on the private equity, I don't have much to say about that other than that was a multi-year effort to get that passed. And we shall see how that gets implemented in the future.
And then Cher, what can they do as an individual physician to help with the problem?
Oh, I love that kind of question. You can join the ANCO MOASC email list and subscribe to their email list. You can go on our website. We are launching a brand new advocacy tool. So we'll be able to send texts and emails that tell you exactly when we want you to call your legislator. And it will be a handy dandy, or email your legislator, and it'll be a handy dandy button that you just push. The message to your legislator will be populated, and all you have to do is hit send. And I can't tell you enough about how much that type of real grassroots advocacy makes a difference. Also, I always need expert witnesses to testify in the legislature on bills that are meant to help our physician community and our patient population. And so when we need an expert witness, we can tell Courtney and Nicole, hey, we need an expert witness. And any of you who are physicians who would like to come to Sacramento and testify before the legislature, your voice is so powerful and we greatly need it. So those are a couple of ways that you can help us in the future, especially as we navigate a very difficult year in 2026.
Yeah. And we also encourage you to join our advocacy committee. and the California Cancer Caucus. You can reach out to me at courtney@anco.org and I can help you get set up with any of our committees.
All right. Well, thank you everyone for attending today. And if you have any follow-up questions, feel free to send those to Courtney and she can forward them to me and I can answer you via email.